Yeah. Hi everyone again. I think you have a great noon and it's a break time. So today we continue our summer learning series, and then the topic of our learning series is like the culture of care, embracing root and elevating practice. So today is August 28th. We are in our fourth presentation. Then the purpose of learning theory first is to design for mental health care provider and care team, including community health worker who support patient and family adapting to the new care system, environment, or cultural context. The session will focus on building practical relationship central approach that strengthen communication, trust, and continuity of care across clinical and community setting. Each session offers a practical tool. So here we serve family who are new here in Maine. We foster meaningful interaction across cultural background and strength trust and communication in clinical and community care setting. So we want a little bit to acknowledge this project is funded by Maine Department of Health and Human Services, Office of Behavioral Health through the Pediatric Mental Health Care Access Grant and supported by the Health Resource Service Administration, someone called ERSA. And then we want to let you know that this learning series is developed and delivered by MCD Global Health in collaboration with Maine Pediatric and Behavioral Health Partner. So the session, I want just to go a little bit in our housekeeping. First of all participants are muted. The webinar is being recorded as we are doing since we begin the session. And you could have a live transcription if you want, and you could go just in your three dot. If you did not see the more, you have three dot on both of your bar. You could just click there and you will find the caption. And then type any question or comment you have for the instructor in the chat box. We will address as many as we can and soon as possible. Also, please use the Q&A button for technical issue or question like you did not have a good sound, your video is just not working well. Please try to go in Q&A, and if you did not hear what the instructor speak or the speaker, just go in the Q&A answer. Also, at the end of this webinar, we'll request that you stay a little bit 2 minutes to answer our evaluation question and then for future. So this webinar is in partnership first with the Department of Health and Human Services. We have Maine Pediatric Behavioral Health Partnership. We have MCD Global Health who provide us a platform and all this organization and logistic. And also we have a Community Workforce Institute who provide us a speaker today, who is our Marilyn Gardner. A little bit about Marilyn, but I know she will go in deep with her presentation, but little just highlight something you could take as a takeaway. Marilyn Gardner, she's a nurse and a director of clinical and cross-cultural training at Community Workforce Institute. Marilyn, you have a stage. Thank you so much.
Okay, thank you. And thank you so much to MCD for inviting me to be here today. This topic is probably my favorite in all the world, as evidenced by this is the kind of thing I read when I'm not working. You know, I read about cross-cultural communication. I watch movies about it. I think about it all the time. And that may well be the case with some of you. Ah, it looks like there's just a few of us here, so I'm hoping to be able to do some good introductions in just a minute. But let me introduce you to the topic first, and then we'll go from there. Can I just check and see, is my voice clear enough? Okay, I tend to have a really loud voice, But sometimes on Zoom, I'm afraid that I'll be too loud. And so I try and tone it down. So I've been told by colleagues to ask. And I see so many friends in this group. Solange, so good to see you. Nalita, I see you. Stacy, it's great to be with you. Let me pull this up. Okay. So I've titled this Communicating Across Boundaries. And I think this is a very apt title. It's actually, I began writing under a blog, Communicating Across Boundaries, a number of years ago. But I've stuck with that title because I feel like it really does capture what cross-cultural communication is all about. So we want to look very specifically, though, cross-cultural communication for healthcare professionals, which looks a little different, and we'll take a look at that. When I think about this topic, I always go back to 2015. So that's 10 years ago, right? I mean, it used to be a year ago. Now it's 10 years ago. I can't, time is just so strange. But in 2015, I remember seeing a copy of The Lancet. The Lancet is a medical journal. It's put out by the UK, and it's a global medical journal. So it's not just about Maine, just about the US, it's global. And the front page cover was all about culture and cross-cultural communication. And I found it fascinating because the person who was the main author in this, said this. He said, the systematic neglect of culture is the single biggest barrier to advancing the highest attainable standard of health worldwide. Again, you know, it's not about Maine. It's not about Massachusetts. It's not about the Northeast. It's not about the United States. It's about worldwide. So I think this should really make us stop and pause, right? That if this is the single biggest barrier to advancing the highest attainable standard of health, we best really pay attention to this. And that really stuck with me as I was thinking about planning this. And it makes sense, right? There's planned migrations and there's unplanned migrations. There's diverse social practices. There's emerging diseases. There's pandemics. How health and well-being are understood, how they are negotiated. We're going to be using that word a lot, really matters, and they shape medical knowledge, but not just medical knowledge. What happens with the medical knowledge, how healthcare is understood, how it is practiced, how it is evaluated, how it is received. So I wanted to start with that because I think that this is a huge reason for why this entire series, not just today's, but the entire series exists, and why it is important and why it is well worth funding. A little bit more about me. I came into this topic very naturally. I grew up overseas. I grew up in the country of Pakistan. And so cross-cultural communication from birth was sort of just ingrained in me. I knew I wasn't Pakistani, but when we would come to the United States, I sure didn't feel American. And I was in this world where, in many of the places where my parents lived, we were the only American family. We were the only Western family. We were the only non-Pakistani family. We were the only English-speaking family. We were often we were often one of a very small minority of Christians in where we lived. So the world around us was a world of Muslims and a world of I found out later, I wasn't aware of this when I was younger, but Pakistanis as well come from many different tribes, many different linguistic groups. So there we were in the middle of this mix. And so from birth, I feel like I was interested in this. I had to care about this. This was about survival. This was about learning what mattered to people, what mattered to me, how I could communicate, how they could communicate back. I cut my teeth as a nurse in Pakistan. I became a nurse in the United States and then went right back to Pakistan because what do you do when you graduate from college? You go back home. The difference was that my home was thousands of miles away in the country of Pakistan. So I cut my teeth there as a graduate nurse at a women's and children's hospital. It was the best place to cut my teeth. I realized that I knew so little. I wore my nursing degree so proudly. I was so proud of being a nurse. I was so proud of this newfound knowledge. And then I'm in a place that, first of all, is not school. And I had done, although I had grown up in Pakistan, I had done my medical practice in a Western biomedical model. I hope you remember that. That's a really important phrase. Western biomedicine is something we're going to talk about because it has a culture all its own. Then suddenly I'm transplanted into a rural area in Pakistan at a women's and children's hospital, and I knew nothing. And I needed to learn everything from scratch practically. I had my theory, but I did not know. What I did know is I knew what I didn't know. I know that sounds like sort of I'm talking in a puzzle, but it's true. I knew what I didn't know, and that was a really important piece. Really important piece. So now I want to know about you. I want to know, who you are. There are, let's see, I'm trying to see. About how many do we have on, Christina?
Yeah, there's about 9 or 10.
Okay. I think that it's enough that I'd love to hear your names. Since there's just 9 of you, I'd love to hear your names. And I'm going to ask you to do something that I don't think is necessarily an easy task. If someone asked you to describe your culture, what 2 words or phrases would you use? What 2 words or phrases would you use? And because I am committed to never asking you to do something I'm not willing to do, I will tell you that what describes my culture is passport, family, and faith in reverse order. So passport, family, and faith in reverse order. That's what describes who I am. So I would love to hear from some of you, from all of you, preferably. If you're more comfortable sharing in the chat, I want to invite you to share in the chat. But otherwise, I'd love to start and go around and hear from you. Again, who are you? And then if someone asked you to describe your culture, what 2 words or phrases would you use? And Stacy, I'm going to pick on you to start.
I'm really trying to think hard about it, but I think if I think of culture, immediately go to sweet tea because I'm from Alabama. And caring, I guess it's a caring culture from both places that I'm at.
Sweet tea and caring. I love that. Thank you, Stacy.
You're welcome.
Audra.
Boy, when I think about culture, that's difficult for me as well. Like Stacy said, I think one thing that I can say is vibrant and all around you, even though people don't realize that.
Oh, I love that. All around you. Yeah, I want you to hold on to that because we're going to be talking about that. Thank you, Audra. Stacy.
Good afternoon. My name is Stacy LaFlamme. I'm actually an MCH program manager at the Maine CDC. And for me, when I think about myself, I very much think of family and being like warm and inclusive.
Family, warm and inclusive. Thank you. Jeanette. Oh, I think you wrote in the chat. I believe you did the chat. Happy people and clean. Okay, thank you. I might ask you later to expand on that, but thank you, Jeanette. Solange, my friend.
Nelida too.
Oh, hello everybody. My name is Solange Chetat. I'm coming from Cameroon, the west part of Cameroon. The west part of Cameroon is a part that I can say that hold the country because agricultural, science, knowledge, everything that you can think. So when I think about my culture, really, when I want to think about my culture, I think about traditional, vibrant, family,
Mm,
and royalty. I grew up with, so here I don't see myself royalty. I love it because I don't have any restraint. But when I go back home, there's royalty. We have a lot of restraint. We have servants. We have people. But you know, I grew up in the town, not in the village. So, but blood is always there. So that.
thank you. You really speak to the dual things of royalty, right? Yes, royalty, amazing, but there is a burden that comes along with that.
A lot of burdens. Trust me.
Yeah,
Yeah.
yeah, thank you.
Welcome.
Briella.
Nelida,
Nelly,
hey,
oh, sorry.
yeah.
Hi
Let's hear.
everyone. My name is Briella and I'm from Burundi, East Africa. When I think about my culture, I'll say very, very, very welcoming. And what else? Very welcoming. Very welcoming. And very family oriented as well. But yes.
Okay. Thank you so much.
Can I say
Nelita.
something? Can I say something about Briella's culture?
Yes.
They are very vibrant.
There you go.
Forgot the best part of it. They are very, very vibrant. They have how do you call it? Drummers? Oh, amazing. Their culture is their dance and so on. So she forgot about it.
I love that.
Yes. Music.
So music, it sounds like there's a lot of words to describe that. I love this. Thank you. Nelita.
Thanks. I'm sorry that I cannot be on camera now because I'm still eating, but I'm very happy to hear everyone's. And for me, when it comes to culture, the first thing that comes to my mind, I'm from Peru, for those who don't know me. And so I'm very proud of my culture because we have so much to be proud of. But the highlights for me are like, this is a caring community. We are like community and family oriented. Almost, I will say 99% because nothing is 100%. But faith is part of the culture, along with food and dance. Those are the most like popular things that I can think about. But also the fact that most of people, because of the and unfortunately the corruption, we shouldn't be poor, but there is a lot of places that have experienced poverty, and I'm amazed on how there is strong will and resilience to survive, and the creativity for those especially who are experiencing needs is just amazing. Thank you.
Thank you. You've given us a beautiful picture of that. Thank you. Jennifer.
Hi, I'm Jennifer, community health worker at Hometown Health Center for Newport and Dexter area. I would say for my culture, I would be very happy, family oriented, and caring.
Okay, thank you. And I think we have Casey.
Hello. I apologize for being off camera. I am calling in today, but really wanted to listen into this as best as I could. My name's Casey. I use she, her pronouns. I am a program coordinator for a continuing education nonprofit in Maine in the United States. And to describe my culture, I would definitely say family oriented, food oriented, and all about quality time.
Quality time. Love that. Thank you. Axels, you're not getting off the hook.
So my name is Axel. I could say I came from the country where we never sleep. It's a bad thing, and then we are a official world capital of music, right? We have more artists over there. When you talk about Congolese, the first thing is like the country of Koffi Olomide, the country of Werason is the big singer, you know. They have more than platinum disc, diamond, you know, all of that kind of stuff. So I'm the country of Leopard.
I love it. So music is huge. Thank you. And Christina, I think you put yours in the chat. Is that right?
Yeah, but I can also say it.
I'd love to hear.
Yeah, I'm Christina Leal. I'm the senior program manager at MCD Global Health. My culture is the Mexican culture, and I would describe it as also family oriented, right? Rooted in family, vibrant and friendly as well.
Thank you. Thank you. I think we got everyone. I want to ask you, have you ever done that before? For those of you who have been on one of my workshops, you don't count because I know I've asked you. But other than that, has anyone ever asked you specifically to do this? Okay. And what is it like for you to do it? What is it like for you to communicate parts of your culture?
For me, it's odd.
Okay. And why?
I guess because it's something I don't think about for myself. I think about it when it comes to other people, but not for me.
Bam, right? We think about this as something with other people. And often we think about this as something for someone who has another country after their, who we know is from another country, not necessarily someone who lives next door, who we believe, who perhaps we grew up beside. It's odd, and yet you said something earlier that I think is really critical. Culture is all around us. It is the way we educate. It is the way we choose to do healthcare. It is food. It is traditions. It is music. But there are those subcultures. There's culture. It is all encompassing. I remember a number of years ago doing a cultural competency workshop, and I was with my colleague, and we asked people to use words to just describe culture in general. And this little Italian lady got up and she said, culture? I mean, it's just everything. And just the way her hands, so it wasn't just her words, it was her whole body was speaking into what she thought about culture. And I think that this is why it's so critical that we figure out some of this cross-cultural communication stuff, and we are committed to doing it the rest of our lives. Because this is never going to be a one and done. It's never going to be, I got it. I got this down. Instead, it's going to be a continually learning thing. So thank you. Thank you for starting us off like that and for being willing to share. Any other thoughts on what this was like for you?
So for me, culture, it's something that you still keep when you forget everything.
Okay, you still keep it when you forget everything. Okay, I want us to really keep this in mind because think about patients. Think about patients that are coming into our care, whether it's an emergency or not. They might forget all kinds of other things, but culture is something that gives them foundation. It gives them meaning. It gives them purpose. It gives reason to live. Culture is that important. So when you forget about everything else, you remember culture. I think this is really critically important to remember. Last thoughts before we move on.
I think when I think about culture, I think that as you well describe, all these factors that define your culture, but the culture defines your frame of view. So therefore, your frame of view, it's gonna be present at any setting that you were. When it comes to healthcare setting, sometimes providers tend to be judgmental or expected one way to behave or respond to a certain procedure or treatment. And with cultures, there is no right, no wrong. It's just differences that we need to be humble enough to go down where the patient is in order to provide like quality of service and cultural and linguistic competitive services,
Yeah. There's so much to talk about in what you said, and we're going to get into this and what the general culture of Western medicine, including providers, is in a bit. So hold some of those thoughts, Nalita. I want to take us now back to the slides. Oops. And let's take a look at the objectives quickly. What I want to do is first define communication, because before we can really look at cross-cultural communication, I want us to have a sort of foundational agreement, if you will, on communication in general. Then we'll look at cross-cultural communication. I want to look at three, what I think are very simple main goals of communication in health and human service interactions. Then look at, and this is where I want to spend a lot of time describing key differences between the key communication styles of collectivistic and individualistic cultures. Because when I think about the cultural interactions I've had, when I think about the cross-cultural interactions that I've been invited into by others, whether as a mediator or just to enjoy, so often the key differences come down to collectivistic versus individualistic cultures. Then I want to give you a framework to look at processing collisions. I just got in a car accident. So collisions have a very strong meaning to me. And we'll talk about that and how cross-cultural collisions really can be very much like, they can be very, very much like cross-cultural communication collisions. Then looking at the three communication styles specific to the American healthcare system, and that brings in some of what Nalita just talked about. How do these styles impact communication, and understand and practice steps to negotiating an interaction across cross-cultural differences? This is a huge task, right? Let's put it right out there right now that people get their PhDs in cross-cultural communication. And we're spending an hour and a half on this. But I hope that it will be an hour and a half that it is very well spent. I want to start with something funny but costly. And that is looking at some of the communication gaps that had happened when the West has tried to implement an ad campaign in other countries. So first of all, Coca-Cola did two things at one point in China. At one point, the way they translated Coca-Cola has life came out as Coca-Cola will raise your ancestors from the dead. Now we see Coca-Cola has life, right? Coca-Cola will raise your ancestors from the dead has a completely different meaning. Can you imagine especially in rural villages, it must have been an incredibly popular drink unless you did not like your ancestors and you really did not want to have them. So then they tried to change and they named their product something that sounded like Coca-Cola, but what the characters meant was bite the wax tadpole. Bite the wax tadpole. And so they learned their mistake and they changed it to happiness in the mouth. Very different. Bite the wax tadpole, happiness in the mouth. Fiat actually, theirs was communication of a kind of different sort. They featured an ad where Richard Gere drove a very fancy, Fiat car from Hollywood to Tibet. And he is hated in China. So they released the ad in Italy, but he was hated in China. So when China saw these messages, they refused to buy Fiat cars. So they saw their sales go way, way down. Kentucky Fried Chicken. It hasn't happened just once in China, but Kentucky Fried Chicken came out as, how we hear they eat it's finger licking good. And people, think of that, especially in the South. I'm looking at Stacy here, right? You think of fried chicken and you're eating it with your fingers and you're licking your fingers off. And instead it came out as eat your fingers off. So these were funny, right? But they cost a lot of money to correct, a lot of money to correct. So I think sometimes when we look at cross-cultural marketing mistakes, it can be a humorous way of understanding what the impact is of poor cultural awareness, poor cross-cultural communication or translation, right? And I can laugh at these, but you better believe that around tables in the United States, around executive boards, this was not a laughing matter because the brand was in danger, because there was a danger to the bottom line. And we know in business, the bottom line is making money. So when there's a danger to the bottom line, it's no longer funny. We can still laugh about it, but it's no longer funny. So that's business. Now let's go to healthcare. And this is where it can be funny. I've had some very funny things happen in terms of cross-cultural communication and cross-cultural mistakes. But what I want to talk about is something that actually was not funny. And I want to talk to you about something that we call the $71 million word. Have any one of you heard of the $71 million word? Okay, so this is a story, true story. This happened in the 80s. And a young man who was 18 years old by the name of Willie Ramirez had just graduated from high school. His buddy came over to pick him up to take him on a ride. This is in South Florida. So he goes on a ride with his buddy, and partway through this ride, he suddenly gets this terrible, terrible headache. They think it's fumes in the car. They don't think this is going to be a problem, but suddenly Willie says, "You have got to take me home." He walks into his house and he falls down onto the carpet in the living room and he's unconscious. They call 911. They get him to the emergency room. His friends and his family are trying to explain what happened to the paramedics and to the doctors and to the emergency room staff. And they only spoke Spanish. While there was a bilingual staff member, there was not a trained interpreter, and a word was used. And this word was the word intoxicado. Now, intoxicado, when it was used, the bilingual staff member assumed and then interpreted it as such that it meant he was intoxicated. Had they asked more questions, they would have found out that this kid was an athlete. He was on a scholarship to go as an athlete to college, and he never used drugs and he never used alcohol. He was straight as an arrow in that regard. And so they did no further testing. They put him in a room, and 2 days later, he woke up as a quadriplegic. There are many, many things about this story that are disturbing. There's a power dynamic where an immigrant family from Cuba does not feel they have the right to question things. There's communication, there's lack of adequate interpretation. Willie Ramirez and his family won the lawsuit, and it was a lawsuit of $71 million. It was a settlement of $71 million. Those of us who do a lot of work in this field call this the $71 million word. Had they bothered to ask further, they would have found out that they were using intoxicado as a sense of not feeling well, not being well. It was nothing to do with being intoxicated. It was nothing to do with alcohol, but no questions were ever asked. So I want us to stop for a minute and think about this, right? If it had been an English-speaking family who was well-versed in the healthcare system, it still would have been hard, right? Because it's hard to explain to people that have an opinion and have already made their assessment. They have already decided who you are and what you deserve. So you have just come into the ER. They've already decided. This is something that it is so important to me that we talk about this and we talk about it and we talk about it more so that we can be models of taking a step back and not making assumptions and looking at the entire story, right? Because the entire story tells us things that a single part is never, ever going to tell us. So if it had been an English-speaking family and they'd been there, there still would have been a power dynamic because that's what happens in a hospital. There are people that are in charge and there are people that have incredible expertise and incredible ability to help us in emergencies. And there are also people that are busy and sometimes need to take that step back and need to be able to bring people into the mix that can help them take that step back and understand better. So this is a costly but not funny story. And so we look at those, the funny ads, and we look at, okay, so money was lost. This was $71 million. One word, one patient, an entire story wrapped around that word. Before I go on, I just want to check because it is a heavy story. Any thoughts or reactions to that story?
It makes me angry for that person and for that family that they, didn't bother to even try to get someone who could sit down and talk with, and they let it go on for 2 days. Yeah.
2 days.
Yeah. Not acceptable.
Right. And I think a righteous anger comes up, right? Just this kind of righteous anger of this is so wrong. What I fear is that things like this, they might not have a $71 million and a quadriplegic implication. But what I fear is that around the country, things are happening like this all the time. And that's what we want to change. We want to be a model for something that is different. So when we think about communication, before I go to the next slide, I just want to ask, what are the different ways that we communicate, just in general?
So
What are different, sorry,
gesture, we could communicate by gesture or
gestures,
writing.
speaking,
So verbal,
gestures,
nonverbal.
writing, verbal, nonverbal,
Even the eyes. You can
eyes.
communicate with your eyes.
You can communicate with your eyes.
Oh,
I
yeah.
have had people say some really nice things and their eyes were very cold. Audra?
We all have micro expressions that we don't even realize we're doing. There's that.
Oh my gosh, have you all seen the meme? I need to teach my face to learn to use its inside voice.
Yes.
That is me. It's like, okay, we have friends here. We can all use our facial inside voices. It's the way our body reacts, right? Suddenly you can see someone tense up. The tone of voice. You know, I can look at Christine and say, wow, look at that outfit. Or, wow, look at that outfit. Totally different meanings. Nalita says the way you walk, the way you talk, the way you dress. How many of you have heard of the 7-38-55 rule? I always have to look at my notes with this so I remember what the actual numbers are. 7-38-55. It's a rule that states that 7% of meaning is communicated through the spoken word, 38% is through the tone of voice, and 55% is through body language. So 7% verbal, 38% tone, 55% through body language. And then you bring in cross-cultural communication to the mix, and that mixes it all up, because our body language in one culture could be very, very different, or probably is very different from the other culture. So that's the 7-38-55 rule.
Solange want to say something?
Oh, Solange, yes.
Yes, I was talking about the 7-35-55 and saying that it's true what you said, because when I first came to the US, you know, for me, when I want to listen to you, I will fold my hands and really pay attention, because folding my hands will give me the equilibrium, so the balance with myself, and also will make me really pay attention to you. But here it seems like folding your hands is that you are getting ready to fight, or you know, that was kind of a little bit difficult. And then also the fact that
Yes.
here you have to look you have to look at someone into the eyes, instead of, you know, we grew up, and even my son today will talk to you. If he respects you, he will not look at you in the eyes, because that's the culture.
Yeah. And so you taught him that, right? You taught him to
Yeah.
be a respectful man. And a respectful man is careful and defers. And yet someone is going to capture that and say, wait a minute, he was disrespectful. He won't look me in the eye. He must be guilty. He won't look me in the eye. Right? It gets so tricky. So communication itself is, I'm giving a really, really simple definition here because I think that serves us well. It's the imparting or the exchanging of information. Cross-cultural communication, then, is the process of recognizing the differences and the similarities among cultural groups as well as individuals when you're imparting or exchanging information. And the whole purpose is to effectively engage within a given context. Our context here is healthcare. That's what we're talking about, healthcare and human services. So we're talking about cross-cultural communication. That's the process of recognizing differences and similarities among groups, among individuals, as we learn to impart or exchange information and effectively engage with them. I think the important words are effectively engage within a healthcare context. I'd like to suggest 3 really simple goals. This has stood me really well in my nursing career. The goals of communication: to gather good information, to give good information, and to build trust. Of course, we can't give good information till we first gather good information. Where these 3 simple goals get tricky, they get tricky when it comes to a cross-cultural interaction. So let's say I'm working with a patient. Let's say I'm working with Brittany. Brittany is 25 years old. Brittany's raised in Hallowell, and she has been referred to me because, let's say, I'm a maternal child health community health worker. I'm actually going to change out my earbuds. Can you hear me? Still hear me okay? Thumbs up? Okay, great. So Brittany lives in Hallowell. She is pregnant. She's pregnant with her first child. She still has her family as her main system of support. I'm given her information to contact her to see what her needs are as she goes through this pregnancy. So that's my first patient. My second patient is Amani. Amani is from the Democratic Republic of Congo. She arrived in the country a year ago, and she's a new Mainer with no family support. So Brittany is here. Brittany's in Hallowell, first pregnancy. So there's still going to be things she doesn't understand. There's still going to be things that she needs, resources she needs. Amani, who is pretty much brand new, no family support, and she too is pregnant with her first child. The information I gather for Brittany is going to look completely different than the information that I gather for Amani. If I think that I can use the same information, I am not practicing cross-cultural communication. A new Mainer, no family support. So the goals are the same. The goals are still, for both of these patients, I want to do these things. I want to gather good information, I want to give good information, and I want to build trust. So good info for Amani is going to be about how to navigate the American medical system. Building trust is going to be about asking her questions about her culture. Building trust is going to be about not assuming that because another person is from DRC that they're automatically going to get along, right? So these 3 simple goals suddenly get layer after layer after layer of complexity. And here's why, partly. We know that there are poorer patient outcomes with communication as a barrier. There's patient dissatisfaction, and that makes all the sense in the world. Do you think Willie Ramirez's family, if they were asked to fill in a satisfaction survey, what do you think they would have put on a scale of 1 to 10? It would be complete zeros, complete dissatisfaction. And that makes sense. Of course, the basic things of gathering good information, giving good information, building trust, when that level of complexity is not navigated, then we have these things. We have poor patient outcomes. We have patient dissatisfaction, financial implications, $71 million word. But we also have other things, Amani might end up in the hospital because she doesn't know. Let's say she ends up with gestational diabetes. She has no clue what's going on with her body, nor does she know who to ask. So there's going to be financial implications of a hospitalization that didn't necessarily need to happen. Need for interpretation and translation services. I think it's really important that we recognize, because I've seen this before, where someone has and I've seen this in myself, believe me, where someone has a basic knowledge and thinks they can navigate of a language and thinks they can navigate an interaction, only to get way over their heads. Because when we have a basic knowledge of a language, we're fine as long as we're controlling the conversation. But the minute that conversation goes beyond our ability, we're lost. And if we've taken this on, it takes a lot of humility to pull back and say, I can't do this. I need to stop this visit right now, and I need to get a professional interpreter. And then poor health literacy. We know that poor health literacy is not just about speaking another language at all. In fact, any of you who have seen the very excellent American Medical Association film on health literacy, it's very clear there. I'll try and put that into the chat as a resource, because it's an excellent, excellent film. And it really does highlight, this isn't just about limited English proficiency. We also know that when there is limited English proficiency, health literacy can be a huge barrier. So keeping in mind both those things. When I think about cross-cultural communication, too, I think about this collision I just had. So my family was coming to us. I have a big family. I have a lot of kids. I now have 4 grandchildren, and they were all coming to visit except for the son who lives in Greece. And we were feeling sorry for him until we saw where he was staying in Greece. So that's a whole side thing. But I was in this collision. Now, it was around a rotary. How many of you moved to the New England area and learned about rotaries? Do they have a lot of rotaries in Maine?
Yes.
Okay, what was
I'd never encountered a rotary till I moved to Maine.
Right? And they really throw you, right? It's like jumping rope. So
I will change routes to avoid rotaries.
Well, I kind of wish the guy who hit me had. So there's this collision, right? No one was hurt. I was really grateful. One of my grandchildren was in the car. My daughter was in the car. I was really grateful. No one was hurt. But it was very similar to the collision that you see in this picture, right? And I was so grateful. But after the collision was when all the impact hit me. So though no one was injured, there were no flashing lights, there was no police officer, there was no ambulance, there was no hospital visit, there were still significant implications to that collision. We only just replaced the car that was totaled. There was insurance, there was his insurance, there was trying to get alternative transportation in an area that doesn't have public transportation. It went on and on. Cross-cultural communication is a bit like entering a rotary. You're going along and you think you're in the right lane, and then bam, you're not quite sure what happened. So let's look back again at this, at Amani, who's our prenatal patient and her first baby from the DRC. I'm talking to Amani, and I want to give her good information, right? I care. I heard in so many of your descriptions of your culture, I heard caring. And it makes sense because you've picked occupations that are caring, that are based on caring. So I want to help Amani. I want to connect with her. And so I mentioned a woman that I know who works in my organization who is from the DRC. And I'm so excited because I think she's going to be a perfect person to communicate with Amani in ways that I can't. And suddenly, I just see this. Amani cannot wait to have this visit over. It's like she wants to go, and her willingness to communicate with me is completely over. So let me just show you a framework, if you will, and then I want to talk about it as a group about what might be going on with Amani. So what just happened? In my case with Amani, I want to first stop because I know there's something going on. She was willing to communicate. We were laughing together. We were attempting to cross linguistic barriers. Her English is good enough to do some communicating, but something happened and I don't have a clue what it is. It's way beyond what I know and what my cultural context is. So the first thing that I want to do is I want to stop and I want to describe what's going on. Not to Amani. This is in my own figuring out what happened. What did you see and hear? And so be as literal as possible. The patient stopped talking and became agitated when physician tried to begin the exam without her husband in the room. Rather than interpreting it. You don't want to interpret it, right? First, you want to describe it. And then you want to spell out what you think, what your cultural interpretations are, what your reactions are, but you want to find out what's going on in their head because your interpretations could be completely wrong. So thinking about this framework, stopping, and thinking about that, and then describing what happened, and then putting interpretations. What do you think happened? Help me describe this.
I think normal cultural values are different from one area to another. So there may have been a total different cultural acceptance of, this male person being in the room with her without her husband present, kind of thing, period. But then I also think, when we're thinking about like everybody's from, if we're thinking about bringing somebody else that's from the same area or same, that's just like saying that, all people that are, from one area, they could speak totally different languages. There could be different realms of people and who's accepted and who can speak to who. And, so there's a whole layer of social that could be going on also.
That's right. A whole layer of social interactions that we're not aware of. Audra.
So I'm going to take it a little bit differently.
Okay.
I wonder if she's feeling like maybe you're giving up on her.
Okay. So let's take a step back. Let's describe what you heard me say. So, let's say we're colleagues, we're talking, and I'm telling you what happened. So describe what you heard me say about Amani. Just describe it without putting any meaning on it.
What I hear is that you say she's a new Mainer.
Mm-hmm.
Let me go back to, hold on.
Right, no hurry.
Well, I mean, that's the biggest thing that stands out to me. Like, she's a new Mainer. She's probably
a new
scared.
Mainer. And suddenly we're there. And, if I'm going to describe it without putting any cultural context on it, I'll say, Audra, I was in the room with her and things were going really well. And then suddenly she wanted to leave. So that's describing it. Suddenly she wanted to leave. And it was after I talked about this other person. So it was after I talked about connecting her with this other person. So then if I talk to someone that maybe knows more, maybe there's a tribal difference, right? Maybe there is a linguistic difference. Maybe in the community, there's a connection that isn't really a connection with her and this person. And I'm making an assumption completely based on the fact that they're from the same country. So what I like about this framework is initially it takes the emotion out, right? Because when I know someone doesn't want to communicate with me, I feel it. I feel upset. I feel hurt. I feel like I'm not doing a good job as a nurse. I feel like I'm blowing it. I feel many things. But if I just stop and say, okay, I'm going to put my emotions aside and I'm just going to describe what happened, then I'm in a better place to maybe interpret it and then ask for help interpreting it. So in my case, I'm going to Axel because Axel knows more about the community. He is from the community. And so I can say to him, this is what happened. So Axel, I'm going to hand it over to you. This is what happened. Well, I'm talking to her. What do you think was going on? Why did she suddenly not want to talk to me?
First of all, I will say maybe you say she's from DRC, right?
Mm-hmm.
I would say the first thing would be a barrier. She's coming from French country and you speak English. Maybe you did not really understand each other. And she feel like if she stay there, she will waste her time for nothing. And she sadly stop conversation and leave.
Okay, that goes somewhat with some of what Audra was saying as well. Okay, so it might not be tribal at all. It might be tribal, but it might not be. It might be just, no, I need to get with someone that really can communicate in the language that I'm most comfortable with.
Also the trust, it's a piece of puzzle that could miss. You say, she's coming from another culture. Why do I need to be open with her? And she looks at herself and she leaves.
Exactly. It's like, I don't know her. I could have asked a question that seemed really invasive to her and that she felt like, you know what? This makes no sense. So that's cross-cultural collisions. Let's move into the areas where I see more cultural collisions than I could possibly count in any given day. And this is around individualists versus collectivists. I know some of you may well have studied this. Some of you may have had anthropology classes or backgrounds. But basically, individualists and individualistic culture, this is a culture that would emphasize personal goals, would emphasize autonomy, self-reliance. An individualistic culture, individuals are encouraged to pursue their own interests. They're encouraged to pursue their own uniqueness, and they're encouraged to be defined by their individual accomplishments. These are countries like the United States, Canada, and Australia. Those are the three top ones that really exemplify individualistic cultural beliefs. And then there's collectivistic. Collectivistic cultures, by contrast, they will prioritize not the needs of the individual, but the needs and the goals of the group over those of the individual. Their goal is harmony, cooperation, and interdependence. So this is really different from self-reliance, autonomy, and personal goals. They define themselves not by their own unique accomplishments, but by their family, by their community, by their country. So look at these two pictures. These pictures tell 1,000 words. You have on the one side, you have the person who is really exemplifies that individualistic culture, that satisfaction with the job they're doing, that this is about my goals, this is about my achievements. And then you have this other picture where it's a relaxed picture of women together with children. It looks really, these two look really, really different. Let's look at a chart. So that was the picture. Let's look at the chart. With individualism, the identity is based on the individual. And in collectivism, it's based on one's social network or social standing. The work relationship is totally different. The work relationship for an individualistic culture is contract based, and with collectivism, it's like it's a family link. It's seen completely differently. It's seen as something that is more in moral terms. Then task is more important than relationship over task. Okay, how many of you in a work setting where you're in an office, it's important to you before you begin the day to start with coffee and chat?
That depends.
It depends. Okay. It depends on if you're with Americans or if you're with.
No, anyway, for me, it depends. But to tell the truth, I have to start my day with my sparkling water.
Okay, your sparkling water. Okay, sparkling water and a friend and a conversation, or sparkling water?
Oh, I always have conversation because when I come here, when I park, I have the security guard that I greet, and then I have the person at the reception that I have to greet, and so on. And then in the elevator, I will meet patients, I will meet other people, and the way to my office, I have to say hello to two or three or four people, and so on. So
Absolutely, because harmony is important, because relationships are more important than tasks, right? So after growing up in Pakistan, I lived in Egypt and Pakistan again. I lived as an adult and worked there, Egypt, and then Iraq. And all three of those countries, it's about the relationship. It's about harmony of the group. It's this next is really important. Low context communication versus high context. Direct communication, telling people directly what they should do and what you think of them or what you think of the situation, versus indirect, speaking indirectly. Rule breaking. Rule breaking in an individualistic culture, it leads to guilt, it leads to loss of respect. But rule breaking in a collectivistic leads to shame and sometimes loss of standing within the community. And then management, it looks totally different. We have a whole other chart here, and I'm going to be sending this out. I'm going to have Christina and Axel get this out to you so that you have this, because I think this is so important. The we identity versus the I identity, relational versus independent, the goals for the group versus oneself. So how does this play out then in a healthcare situation? Audra.
Thank you. Before you go too much further,
Yes.
Can folks be in both of those groups though?
Yes,
Safely?
I absolutely think they can. And I think that there is this between place that many of us who have lived in collectivistic and individualistic societies, I think many of us, or even people who haven't, but who have worked in both or have seen both firsthand, I think we see the strengths and the weaknesses of both. And we want to pick something in the middle that says, because individualistic cultures, the creativity that comes out of individualistic cultures is bar none. You cannot top the creativity. It is one of the reasons why the United States is such a place where people want to come to for innovation. They want to come to for their research. They want to come to for business practices because of these things. And yet people also want community. They want this sense of family. Where we get into trouble in healthcare contexts is when the person from the individualistic society with the strong cultural boundaries, if you will, of Western biomedicine and the American medical system are communicating with the collectivist. The collectivist doesn't want to know about the disease. They want their family to know. I'm giving a generalization, so that this doesn't mean everyone, but I have been in so many places where there is this tremendous tension. The doctor wants to give the cancer diagnosis. The cultural broker is there saying, you can't, the family is not there. The doctor says, it's not important that the family is not there. This is her decision. It's her decision what to do. It's her decision how to handle this, whether to have chemo. So that's what's important. The cultural broker is like, no, 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 no. That is not the case. That's not the case. The family will want to know first. The doctor's like, absolutely not. There's something called HIPAA. And you see how this goes on. Solange. Oh, you're muted.
And that's true because sometimes some providers are stubborn. They don't understand why family members said no, or why the cultural, it's the same thing with the cultural doulas, the cultural uh, uh, um, community health workers, and so on. Because the thing is that the doctor, for him, is just like, oh, the patient is the patient. But the doctors sometimes don't know the mentality or the mental state of the patient. But the cultural CHW or the cultural doula knows that the family should be there before it's giving, a diagnostic. Because you don't know. Some people you give that, they commit suicide because they don't understand. And that's what I think that the example that you are saying is the typical example that we see every single day. Like the doctor doesn't want to listen to you. What I usually do is that I usually go, especially when it's midwives and so on, I will go sit down with them and say, okay, the patient is this. So please mind for this, that. And then if you need help, just call me. I will know how to say it to the patient or, and
Yes.
it's not easy.
Yes, you've given a perfect example, right? And we can see this play out all day long. Sense of belonging, right? That sense of belonging, the individualist wants that sense of independence. But if belonging comes within the group, that's going to be a disconnect, a hierarchy. There are times where someone from a collectivistic society wants to question a doctor, but there is a level of respect, a deep level of respect for them. And even if they have this sense that this doesn't seem right, they won't question them. That's where we come in. And that's where we get to say, do you have questions for the doctor? Because I can help you ask those questions. It is not disrespectful to ask those questions. I feel like this collectivistic and individualistic, these pieces are such a huge part of the collisions we see, and yet we do not talk about them. I wanted to show you a little video, but I am because in the interest of time. But when you get home or when you get this presentation, take a look at this because this song from Mulan is perfect. They are dressing her to be presented as a possible bride. And as they're dressing her, as they're making her up, the words are, you'll bring honor to us all. Not you're going to find a great husband, not you're going to be fulfilled in a marriage where the two of you move forward. None of that. No, it's you'll bring honor to us all. This is not about you, Milan. This is about all of us. And your job is to bring honor to us. Our patients are often in the same place. Let's contrast what you saw about collectivism and individualism to these three communication styles that are very specific to Western medicine. Verbalization, We depend on verbalization. Patients are expected to verbalize what they feel, what they think, their medical needs, their concerns. And healthcare providers, we depend on that, right? But what if verbalization is not part of the cultural context? Directness. Because we know that information is critical, right? It's critical that we get good information from patients as well. And it's critical for accurate diagnoses. It's critical to know what a patient needs. And yet, when there's indirect modes of expression, these questions might feel really invasive for a patient. And we may, a patient might use body language and verbal and nonverbal expressions to communicate things as opposed to verbalization and directness. And then disclosure. We are all about disclosure, right? We have HIPAA because of disclosure. I need to find the citation of that, but I have read in several places that 3/4 of the world operates on a family system and structure of support, and 1/4 of the world operates on an institutional system. So when you have someone from this family system and the institution is looking at being that support, there's tension. There can be a major collision. So again, I feel like understanding these things, we're not going to change the system. We might change some things, and I hope so. What we can do, though, is when we know this, we are better prepared then to meet our patients who are from these different backgrounds and who do not communicate through verbalization or directness or disclosure. They are not values that are held. They are not things that are understood or are important to the person. So we can't possibly know everything about every community and every culture that we serve. It's an impossibility. What we can do is we can have tools that help us navigate. And in these last 5 minutes, I just wanted to give you a few of the ones that I think can be helpful. Cultural humility. In this series, I know that this has been mentioned before. Know what we don't know. The heart of cultural humility is understanding that we're not experts on the person in front of us. We come into the relationship with expertise, and that is not nothing. That's important. We got the jobs we have because we have expertise. What we don't know is we do not automatically know the culture of the patient. And that's even if they look exactly like us and have the same language. They are the experts. If we're from the community, we're in a much better place to fully understand. But even then, we must exercise cultural humility. And cultural humility is a lifelong pursuit. It's never over. Just like cross-cultural communication and communicating cross-culturally is never over. Learn the art of negotiation. I really think there is a whole art to this. And I've watched people do this so well in really hard conversations about birth control, about vaccines, about receiving chemotherapy, about end-of-life care. First, the very first thing is to ask the person what their perspective is. It's way more important that we know. And I would say this in general, the crucial question is not, what happened to this patient? It's how does this patient interpret what happened to them? So not what happened to them. It's not what disease they have, but how they perceive the disease they have, what they think is going to happen. Asking them to explain that viewpoint, then asking permission to share your own, then saying, what do you think would make you better. And saying, thank you for sharing that. Now may I share what I think could make you better. Cultural brokers. Using cultural brokers is an act of cultural humility. It's saying, I don't know. I have got to bring other people into this so that I can better understand. Listening. I have had to really learn how to listen. We're far too quick to use our expertise and our expert knowledge instead of first gathering from the patient what we need in order to share our expertise. And then using the shortened explanatory model. How many of you have heard of the explanatory model? I love this model. This model was developed by a medical anthropologist. It makes sense. He had done ethnographies in villages, and his whole thing is we don't need cultural competency in the clinic. We need anthropology in the clinic. We need someone we need to ask the right questions so the person shares their view of life, of their needs, of illness. So he developed 8 questions, and you'll be getting this when they go out to you. And they're, what do you think has caused your illness? Ooh, the most important one here is not here. What do you call this illness? Is the very first and most important one. If you ask someone about diabetes, what do you call this illness? And they tell you they call it sugar death. You've just learned a lot about their views about diabetes. And there's a lot of teaching that needs to go. Just like if they call it a touch of the sugar, there's a lot of teaching because diabetes is a complicated illness. So going through these questions can help you get the insider's view. But who has time for 8 questions, right? And this is where the nursing model comes in. And it's called the explanatory model. Simplify, call, cause, cope or cure, and concern. What do you call your problem? I call it sugar death. What do you think caused your problem? I ate too much rice. What do you think would make it better? I just need to not eat so much rice. What are your concerns about this sugar death or, this touch of the sugar? What are your concerns? That I will die, that I will not be able to eat the things I want. Those are 2 different things. If you have a patient that says, my biggest concern is that I will die, and another patient that says, my biggest concern is that I can't eat the foods, you're going to work with them in different ways. And you want to understand why they think they'll die. There could be very good reasons. They could come from a rural area in Pakistan where there was no treatment. And so everyone they know who had diabetes did indeed die. The final thing, and I know I need to turn this over, is this, the triad of cultural care. I love this. Curiosity, empathy, and respect. This is the biggest tool of all, right? It's exploring, it's being willing to, be interested, explore the patient's unique perspectives, and then that respect, being open to their thoughts, being open to their perspective. And then lastly, that importance of empathy, of caring for them, of being willing to hear them and to respond with deep empathy. We might not have gone through exactly what our patients have, but we know the core of pain. We know the core. Every one of us could probably think of a time where we felt like we did not belong. We know the core of not belonging. We know these cores. With that, when I first heard an hour and a half, I thought, oh, thank you so much for giving me an hour and a half, not just an hour. And now I want 2 hours, 3 hours with you all. So with that, I am going to transfer it over and just say thank you so much.
Thank you so much, Marilyn, for your great presentation. I think we really understand what means cross-cultural communication right now. I think all of us just bring something as a tool. For someone who maybe came and joined us when Marian was presenting, I just want to introduce her again. She's a director of clinical and cross-cultural training at Community Workforce Institute. She's based in Massachusetts. So we want to continue our webinar. One just to let you know a little bit about Men Pediatric and Behavioral Health Partnership. The mission is to educate, support, and empower pediatric care provider and the clinical team member through the training and ongoing web-based and telephonic patient care consultation with behavioral health provider. And then I think I will put just here in the chat if you want to enroll in the behavioral health. I put the link there. You could just go there, you could enroll, and then the phone number is a little bit down. And at the same time, I launched a pool for our presentation. And here, I just want to let you know that our next session will be on September 4, and the topic will be enhancing early development support in men, specifically in men. And it will be just 1 hour. Today, I think it was 1 hour and a half. And for upcoming event, I just want to give Christina a little stage. She could just give us more detail about it, and just scroll down and answer the evaluation, please.
Yeah, as you all are answering the evaluation, I'll just jump in really quickly with information on we're having an in-person workshop that is going to wrap up these important conversations that we've been having. I shared the link in the chat, but we are looking forward to bringing health providers, care teams, CHWs who are part of care teams, community leaders, to discuss more on how we can build trust between the community and the health providers. So, and we thank you so much for having joined us today. And thank you, Marilyn, again. Over to you,
Thank
Axis.
you.
Yeah, thank you so much. At the same time, we are finishing our poll. It just remained maybe one person. And then this is our contact about this webinar series. If you want just to contact us, this is an email, or you could just shoot me a quick email directly. I will answer to all of your questions. I don't know if you have any question, and then we are here to answer. Thank you so much for your time to attend this webinar.